Welcome viewers. Today we will be talking about another important and common topic of urology, which is urethral stricture. Urethral stricture means a narrowing in the lumen or caliber of the anterior urethra. Especially this is a disease of male urethra. So in males, the urethra is about 20 to 25 centimeters long. And it is divided into many parts like the prostatic urethra, the membranous urethra, the bulbar urethra, the penile urethra and the meatus. So usually the bulbar urethra, penile urethra and the meatus together are considered as the anterior urethra. So any narrowing that happens in the course of the anterior urethra is labeled as a urethral stricture. So in the past, when safe sex practices were not common, one of the common causes, rather to say the commonest cause of urethral stricture used to be infective. But with the awareness currently and with the use of safe sexual practices, the infective causes of urethral stricture has come down. Currently, the most common cause of urethral stricture is actually idiopathic. Idiopathic means there is no obvious identifiable cause of the stricture. The other important causes of urethral stricture includes either infective, inflammatory or traumatic. So either due to a previous catheterization or urethral instrumentation, urethral stricture can occur, which is called traumatic urethral stricture. It can also be due to inflammation in the urethra. One common inflammatory disease is called BXO or balanitis xerotica obliterans, in which entire urethra as well as the glans penis becomes white in color due to the fibrosis and scarring. Urethral stricture can be classified based on their etiology, that means the cause of the urethral stricture, based on the location of the urethral stricture or based on the caliber of the urethral stricture. So usually the cause of urethral stricture I will deal in my next question. Common causes include either infection or trauma or inflammatory diseases, or it can be unknown. So based on the caliber, we can classify urethral stricture depending on the diameter of the lumen of the urethra at the site of the stricture. So this is usually denoted in the units called French or FR. So a urethral stricture which is 6 French, that means the lumen caliber at the site of the stricture is 1/3 of the number, that means 6 divided by 3, that is 2 mm. So the caliber of the lumen is just 2 mm at the site of stricture. Then we label it as a 6 French stricture. So similarly, it can be a 4 French, 5 French, 6 French, 8 French, 9 French, it can be any number. Usually the caliber of the urethra is about 18 to 21 French. So any of the anterior urethra is denoted as stricture, and usually strictures less than 10 French start causing symptoms to the patient. Based on the location of the stricture, we can classify the strictures. So depending on whichever part the stricture is present, say it is present in the bulbar urethra, then we label it as bulbar urethral stricture. If it is in the penile urethra, we call it as a penile urethral stricture. If it is present at the meatus or submeatal region, then we call it as a stricture at the meatus or submeatal region. And if the entire anterior urethra is narrow, then we call it as a pan-anterior urethral stricture. As I said, if a urethral stricture is more than 10 French in caliber, say between 10 to 18 French, then it may not cause any symptoms. Only when the stricture caliber is less than 10 French, it usually causes symptoms to the patient. So since there is a narrowing in the passage of urine, therefore there will be symptoms related to passage or stream of urine in the form of poor flow, incomplete voiding, straining to pass urine, dribbling at the end of voiding. Apart from this, there can be infection in the urinary passage which can lead to burning in urine, fever, and at the end stage may even cause retention of urine. Occasionally, urethral stricture can also cause bleeding in the urinary passage or hematuria. Usually, urethral stricture progresses very slowly. However, if the treatment is not taken on time or if it is neglected for a long period, then a long-standing urethral stricture can cause complications. Especially in diabetics or immunocompromised patients, it can cause infection in the urinary passage. The infection can even become serious and it can lead to fever and sepsis. It can cause infection of the kidneys and bloodstream as well. Apart from infection, due to non-passage of urine or incomplete voiding, there can be formation of stones in the urinary passage, especially in the urinary bladder. Also, there can be decompensation of the bladder because the urine is not getting completely emptied from the bladder. And also, another important complication of long-standing obstruction is hydronephrosis. Because of a distal obstruction in the urinary passage, over a period of time, the kidneys also can get affected and they can become dilated. The pelvic ileal system of the kidneys become dilated, which is called hydroureteronephrosis, and ultimately it can lead to renal failure or kidney failure. So when a patient presents with symptoms related to urinary stream, the urologist initially orders a urine routine and microscopy and a uroflowmetry. Urine routine and microscopy may show red blood cells or white blood cells or pus cells. And in uroflowmetry, we usually see a poor flow of urine or a box-shaped flow pattern. This is also called a constrictive flow pattern, which is very typical of a urethral stricture. To correctly identify the site of urethral stricture, the caliber and the number of strictures, we have to do some sort of imaging study. The usual imaging study which is commonly employed for a diagnosis of a stricture is called RGU or retrograde urethrogram. In this test, a iodinated contrast is injected into the urethra from the meatus and an X-ray film is taken, and we can image the entire length of the urethra and identify the location and caliber of the urethral stricture. Also, we can directly visualize the urethral stricture by a test called cystourethropy. In this test, a camera through a scope is inserted into the urethra under anesthesia and the segment of narrowing is directly examined by a camera and photograph can be taken or videography can be done. However, if the stricture caliber is less, then we cannot assess the area of the urethra or bladder which is proximal to the stricture by a cystoscopy, which can be done by a retrograde urethrogram. Usually, a combination of uroflowmetry, retrograde urethrogram and cystoscopy are done to identify and diagnose urethral stricture. To understand the treatment of urethral stricture, we need to understand the natural history of urethral stricture. Usually, strictures are very slow progressive diseases. Depending on the amount of symptom and whether or not the complications are present, and also based on the fitness of the patient, the age profile and other comorbidities, the treatment plan is made. So there are three common modalities of treatment. The first is a watchful waiting or observation. So if the stricture caliber is not very narrow and if the symptoms are mild and if there are no complications, the stricture may be observed for a period of time. However, there are no obvious medical treatment available for stricture disease. The second line of treatment is an endoscopic treatment. So in endoscopic treatment, we can incise on the area of the stricture and make the caliber of the urethra wide at the area of the narrowing. It can be done either with a cold knife or using a laser. This technique is called DVIU, which is direct visual internal urethrotomy. Sometimes it is also referred to as OIU, which is called optical internal urethrotomy, or EIU, which is called endoscopic internal urethrotomy. So DVIU, OIU or EIU mean the same. So in this technique, the urologist inserts an endoscope or a cystoscope or cystourethroskop inside the urethra, examines the urethral stricture and then makes an access by putting a guide wire, following which an optical internal urethrotomy is inserted and incision is made at the site of stricture, either by using a cold knife or by using a laser. And following this incision, a catheter is placed and then the catheter is removed after 3 to 7 days. After this technique, usually the patient needs to calibrate his urethra based on a regimen which the urologist provides him, in which the patient himself introduces gently a lubricated catheter inside the urethra, maybe once a day or as less frequent as once a month. Final treatment is a reconstructive procedure which is called urethroplasty. There are many types of urethroplasty which depends on the site of stricture and the caliber of stricture. Usually long length urethral strictures, which are called pan-anterior urethral strictures or penile urethral strictures, or reoperated cases require staged procedures. Also, if there is infection in the urethra, then also it demands a staged procedure. If there is no infection and if it is a simple urethral stricture which is located at a single point, then usually the treatment involves cutting open of that area of the stricture and augmenting that urethra using a graft. Usually the graft is a buccal mucosal graft. So this is called BMG urethroplasty or buccal mucosal graft urethroplasty. So basically in this procedure, a small mucosa, a small segment of mucosa from the buccal cavity is taken. That means the mucosa is the segment of the inner skin which is there inside the mouth. So that skin part is taken and is put in the area of the urethral stricture, making the urethral caliber wide. The primary graft donor area inside the mouth can be either sutured or can be left open, which heals by about a week's or 2 weeks time. Inside the urethra, after repair or after augmenting that area of stricture using the graft, a catheter is usually placed for 2 to 3 weeks. And after 3 weeks, the patient voids near normally. The success rate of this procedure is in the range of 90%. So to summarize, urethral stricture treatment can be either observation or optical internal urethrotomy or DVIU or endoscopic treatment, or it can be in the form of open surgery or reconstructive surgery called urethroplasty. Safe sexual practice or the use of barrier methods of contraception are an important step to prevent infective cause of urethral stricture. Yes, urethral stricture can be cured by means of surgery. Urethral stricture is not a malignant disease, it's a very benign disease and we usually know the cause of it. So basically it's a narrowing of a segment of urethra. So if the narrowing is removed and if a healthy urethra is joined with another healthy urethra, then it can be considered as cure for the urethral stricture. So a reconstructive surgery of the urethra, which is called urethroplasty, is the best known procedure which can cure the stricture urethra. No, urethral stricture is not fatal, but however, the complications of urethral stricture can at times be dangerous and fatal, especially in diabetic or immunocompromised patients. If infection happens, then the infection can rapidly progress to a urosepsis and that can become fatal. Also, long-standing urethral stricture can lead to dilatation of kidneys, which is called hydrourethronephrosis, and can eventually lead to renal failure, and this renal failure can cause fatality. No, a urethral stricture cannot heal itself. It is basically a surgical condition. Urethral stricture is a surgical condition and it can be cured only by surgery. Because urethral stricture is very slow progressive, some urethral strictures can be observed also. However, there are no good medical treatment available for urethral stricture. Here I would like to highlight that for inflammatory strictures, especially when the cause of the stricture is BXO, after doing surgery, we can apply topical treatment in the form of either a topical steroid cream or a topical immunomodulator or tacrolimus cream, which can help to prevent the recurrence of the stricture, but there are no treatment modalities or medical treatment modalities available for urethral stricture disease. Yes, urethral strictures are known for their recurrence, especially the higher rates of recurrence of up to about 10% are seen for BXO or inflammatory strictures. The BXO related inflammatory strictures are known for their high recurrence rates, and for reducing the rate of recurrence, we can apply topical steroid or immunomodulator medications like clobetasol or tacrolimus. Usually, the narrowing of the urethra occurs in the anterior urethral region in urethral stricture disease, and the passage for semen usually opens in the posterior urethra at the verumontanum. Therefore, urethral stricture usually doesn't cause infertility. However, one important infection we need to remember is a tuberculosis. In tubercular urethral strictures, there can be concomitant fibrosis of the vas deferens or ejaculatory ducts or scarring of the seminal vesicle or epididymis, which can lead to infertility. So, per se, urethral stricture does not cause erectile dysfunction, but the treatment of urethral stricture by endoscopic internal urethrotomy can lead to erectile dysfunction. Usually, when we incise the urethra at the site of stricture, especially when we incise dorsally, that means on the upper wall where the cavernosa is present, it can lead to some cavernosal leak and erectile dysfunction. Usually, stricture is an associated finding which is seen along with benign hypertrophy or enlargement of the prostate, which can be treated at the time of prostate surgery itself. Also, the treatment for BPH by endoscopic procedure can lead to iatrogenic urethral strictures.